Good morning, everyone. I am Michael DeCoco, the chair for Member Advancement Committee for California Association Healthcare Leaders. In behalf of Cal and Sol, I would like to welcome you to the Board of Governors Prep Review session for this fall. It's our 7th series for this session. So I would like to congratulate everyone for taking this first step in achieving your fellow status. So despite it is Saturday and the weather is very nice to be spending outside, you still decided to be with us on this beautiful day. And this shows your commitment to lifelong learning and to your FACHI journey. So what we have in store for you today and for the future Saturdays, we have prepared questions to each body of knowledge, and we will help you on how to achieve the best answers through critical thinking using our brain walk technique as our secret sauce. Unfortunately, we are not here to do the traditional way of review sessions, such as presenting the contents of each body of knowledge. So our main focus is on how to apply the proper techniques of test taking and critical thinking. So before we proceed with the main agenda today, so next slide, please. I would like to introduce the different members of the committee who made this session possible and successful. So I'd like to start with myself. I'm Michael DeCoco. My daytime job is the Director for Ancillary Services for Clinical and Non-Clinical at AHMC Seton Medical Center. And I have been with Cal for 7 years now and ACHE for 7 years now also. I am a FACHE and I have been with the Cal Member Advancement Committee for almost 4 years. So next is Sachin.
Thank you, Michael. Welcome, everyone, for joining us this morning. My name is Sachin Gangupantula. I'm a member of the Advancement Committee. I've been on the committee for close to 4 years as well. And I am a co-founder and run a private medical practice here in Modesto, focused on diabetes and obesity. Been a member of CAL for 7 years or so. Thank you.
Rick.
Morning, everyone. I'm Rick Nerad. I'm Professor of Health Services Administration at California State University, Chico. Been a member, well, actually, I was one of the founding members of the Cal board, so it goes way back. I don't remember the year. And I've been on the Advancement Committee so long, I don't remember that either.
Thank you, Rick. We don't have Sanjit Sood here for today, and we'll move on to Nora.
Hi, Nora Powers. I'm a Director of Northern California Medical Management for Aetna. So some of you may have already heard me say I'm the token payer rep in the chapter. There's a few of us. I've been on this member committee double-digit years. I think I joined in 2011. And it's been incredible to see the evolution of what we've accomplished here. So look forward to working with you over these next few weeks.
Okay, thank you. Next slide, please. And now I'd like to turn over to our partners for San Diego Organization of Healthcare Leaders.
Good morning, everyone. My name is Florencia Romero, and I am the co-chair for the Advancement Study Group Committee at the San Diego Organization of Healthcare Leaders. And I'm currently a business analyst at UCSD Health. And I've been with Sol for 1 year.
Okay. Well, Florencia and I are both from UC San Diego Health. I'm a practice manager there for internal medicine, and I have been with this committee. I joined last year in 2019, and I have been with Sol since 2003. So I think it's going on 21 years. So long time.
Okay, thank you very much, and thank you for your precious time in spending your volunteer time in making this successful review session. So next slide, please. So the next slide will be, I'll be turning it over to Nora. She will be talking about giving us an overview about advancement processes that, and resources that are essential towards the journey. So take it away, Nora. I think you're on mute, Nora.
Oh, I started that out beautifully. No one's ever started talking when they're on mute, right? Okay, so I'm literally going to blast through this entire section just really, really quick. The advantage is all of this is online at the ACHE website. I'm old enough to have gone back when we didn't have websites to go to and have all this fabulous information right at your fingertips. So please feel free to ask questions, you know, at the end of the session. But again, all of this is online. So, and there's an advancement webinar coming on through ICHE. We'll get to that later. But basically, go to ache.org, go under the fellows section, FACHE section, and the world will open up in terms of how to apply, the qualifications, the criteria to even just apply and then sit for the exam. So next slide, please. Okay, so the requirements prior to applying is you need to have 1 year with ACHE and or being a faculty associate or international associate. You have to have an advanced degree, either master's or some other post-baccalaureate degree. You have to have a current healthcare management position and a minimum of 5 years. We've got little asterisks here and there. There is a decision matrix available on the website to help you understand, you know, if you meet the qualifications under the healthcare management position and in the experience. Because sometimes is it whether you have direct reports or if you're in charge of several departments. And so we highly recommend going down there to that particular website. And then you have to have, you know, we're nothing if not good citizens, both in the healthcare sphere, you know, in our industry, as well as in our community. So you have to have 4 volunteer activities within the 3 years prior to submitting these applications, 2 which are community or civic, and then 2 which are healthcare related. Next slide. So this is the decision matrix. And one of the best places to go for this is to your executive leadership team. And they will help, you know, they may point out things that you don't even realize that is important for putting down on this matrix to determine if you meet the qualifications under the experience in the current position. Next slide.
Sorry about that. 1 second.
Okay, so eligibility requirements. Okay, so we're faced at the beginning of the year, it's going to change a little bit. So some of you may want to like apply as quickly as possible and take the exam, but basically you have to have 36 hours of continuing education hours, credits, and a minimum of which 12 have to be through ACHE face-to-face hours. And the website clearly explains what those are. And then up to 24 of the qualified education hours, which are, for example, this session right here is giving you 8 hours of qualified education. It's not directly face-to-face using an ACHE approved template. Okay, so beginning after January 1st, you still have to have the 12 ACHE in person. They call it in person now versus face-to-face. And then for the 24 hours of qualified education, 12 of those need to be what's classified as ACHE virtual interactive education hours. So this is new. The website does a really good job explaining what those are. And particularly for ACHE, they will tell you when you're signing up for something or a presentation, your chapter's doing something, it very clearly will say, you know, these are worth, you know, 1 in-person hour or 2 qualified education hours. And it will also say if this is a virtual interactive education hour. So those are clearly marked, usually. Next slide. Okay, so again, you have to do this before you apply. There used to be a time when you could meet some requirements and then apply for the exam. And then, you know, take the exam and pass the exam, but then you have to finish the other stuff before you'll actually get the fellow credential. Now, no, got to have them done before you apply and sitting for the exam. So again, the examples of volunteer activities. Several of you may have heard me already say this before. For Civic, I was a band booster for my kids' high school band, and I did tap dancing routines at different community centers. It's pretty funny looking, but it qualified. And then 2 healthcare related activities through your organization, American Heart Association. I've done, you know, a Cancer Society, heart and lung, you know, all kinds of stuff. I mean, they all qualify. And then you need 2 references. One reference needs to be at least a structured interview, and the website describes there's a form that gets filled out. It doesn't have to be face to face. It can be over the phone, Zoom, whatever, but it needs to be a structured interview. And then what ACHE tries to get is if you can get a senior level executive from your own organization. Now, the references have to come from someone from ACHE. So we should have said ACHE senior executive in your organization or another current fellow. So only fellows can give these references. I guess we need to clarify that there. And by virtue of being here, just by being here, signing up for this and starting this journey, we are confident that you are going to be the kind of person we want to join to get the fellow credential. So one of us can choose to be, you can choose one of us as your reference. Next slide. Okay, so yeah, I'm just literally going to blast through this. This is all on the website. It's basically you submit the application online, you provide the appropriate documentation. There's an application fee. Then if you receive the authorization letter to then sit for the exam, then there's another registration for that. And that's another application fee for the exam. And then once you schedule it and pay for it, then you have 30 days. And if you don't pass the exam the first time, which sometimes happens, there is a waiting period before you can take it again. 60 days, I think is what it says in there. And then these are computer-based testing at Pearson VUE locations, or you do the paper exam if you ever go to the Congress. Next. Okay, so basic outline, again, this is all on the website. So there's different weightings for the different areas. So basically what we're covering today will be the healthcare section, which is worth 30 questions, which is 15% of the overall scoring. And before we do each presentation, we'll be showing you, the breakdown. Some of this weighting it changes every couple of years in general, but it's pretty consistent that management, leadership, and the healthcare piece and finance are usually like the top. HR is right up there too. One of the things that we'll be pounding it into you throughout this series is all of these, we're not looking state specific. These are nationwide concepts. So particularly as we get into rules and regs, you get into HR stuff, you know, what's good in California is not necessarily national. So keep that in mind. Next. Okay, so there's 230 questions on the exam, but only 200 are scored. The rest are, you know, like sample, they're testing the test questions. Again, it's measuring competence, not so much book learning, although I will not lie, sometimes you do have to know some of your Pareto charts and different finance concepts. But basically, a lot of people have discovered that just by virtue of being in the industry, they have to study, but it's amazing how much you know as you begin to prep for this exam. And so, yeah, we're looking at the application of knowledge, not just recall of facts, but sorry, finance and some other sections. Sometimes you do rules and regs, you do have to know the names and sometimes the dates of the exam of the laws. But in general, we're looking at the application of the knowledge throughout the entire industry.
Just one comment I want to add, Nora, that the 200 questions are aggregate. They're not specific to each domain area, as in a minimum required to score in each domain area. So that's a good. So for folks who are not so strong in finance because you're not necessarily doing it as Zay's job, it's okay if you're not doing so well, but definitely focus on those domains that actually have a higher weightage, so you have a better score.
And thank you for that, Sachin. On the website, there's also a competency assessment document that helps you decide, you know, look and see what your strengths are and where some of your weaknesses are. It can help you focus on where you need to concentrate your studying. Next. So ACHE is nothing if not helpful, with all kinds of resources out there. There's quarterly webinars that are live you can log into. The next one is December 14th to walk you through all the application process. When you go into the FACHE site, you'll see that there's all kinds of links for exam prep resources like study books, and we've got flashcards. We'll share some of that. And we've provided some of the links in here, FAQs, reference lists for studying materials. Next. So they also offer virtual Board of Governors exam review sessions. And it does offer 14 of those valuable face-to-face credit hours that you need. Honestly, I'm sure later we'll show you what the price is. When you break it down price by education credit hour, it's one of the best deals out there. And there's an online tutorial where you can earn 10 qualified education credits.
So there's no more face-to-face Board of Governors exam, or just virtual now, Nora?
Yeah. Well, but it offers the face-to-face education credit. Okay. Yeah. Since the pandemic, they stopped doing them. They used to have them at different locations. And again, going out on the ACHE site will give you some good information. Okay, next. Okay, Sachin, take it away.
Thank you. So we have Cal organizes a combination of face-to-face credits as well as qualified education credits events. This is an upcoming event that's October 17th. I think this year we've already opened up a few events for in person as well. So this one, it still is virtual. Yes. It's a great topic, the business of healthcare. And we have some amazing panelists here who actually are going to shed some light on the current challenges and things that we all have to be mindful about in handling. So if you are able to register, please do. And this is for Sil.
Okay. Well, let me just put on my video real quick so you guys can see me. For those of you who are interested we have an upcoming event on October 19th regarding healthcare innovation. So it's a virtual face-to-face, so you can start earning those virtual hours. So there's the information. If you need to, you can go to our website to register. No, Florencia, do you have anything else to add as far as this upcoming event?
Nope, nothing else to add.
There you go. So Soul's got something coming up this month if you have the time and interest. Thank you.
Okay, so again, the good news is all of this is on the website, everything that we're going to cover here. A lot of people allow 3 to 6 months to prepare for their exam. Again, you'll know yourself best on, and you know, it's interesting if you go out on the Cal site, you know, there's a lot of testimonials from other members that have prepared for and taken the exam and what worked for them. You can assess your competencies. Here's the link to get into the competency matrix to help you assess where you're strong, where you might need to beef up some additional studying. And then, you know, develop your plan, your action plan. And one of the things that we try to encourage this cohort, all our cohorts that go through these, is at the end of the session, we want to send out everybody's email and, you know, contact information. You can let us know if you don't want that, but this way we're trying to encourage some of you to get together and study, you know, create your own study groups. That might help. And again, it depends on your local chapters. ACHE's got resources. At the end of every session, we're going to just send you everything that we've presented. You're getting the recordings, the most excellent recordings from Rick and his other cohort in crime out of Chico. And with those videos, again, these are just a glimpse of what you need to know and what you need to study. But those, we'll be sending all of those to you. And
Yeah, Nora,
again,
can I add
yes.
something to develop a plan? So if you are really determined to take the exam in 6 months, you have to really dedicate at least 2 to 3 hours of uninterrupted learning or reading or studying every day. That's my suggestion, because that's what to be successful.
Good point. Next. Okay, again, these the test will be done at Pearson VUE authorized test centers. The link here will take you to where they're located. I can't remember where the ones here, like in SAC or Northern California, but they're all over the place, right? If I recall correctly, because they don't just do ACHE stuff. They host a bunch of different industries.
Yeah, there are multiple locations. Just to remember that because they're hosting different exams, if you have, for example, I took one in Sacramento, which is almost 70 miles up north for me. But if you are planning to take in a certain location, take a look at them right away for the next few weeks, just to know what your availability looks like in their facility. And that way, they do offer on weekends too. That's the best part.
So again, thank you for that, Sachin. If you, interesting enough down here, if you get an acceptance letter from ACHE to then schedule your exam, well, if you submit the application usually between March and the end of June. ACHE will waive the application fee. No, let me rephrase that. They'll waive the exam fee. So what we always tell people, if you're in the spring, if you're going to submit your application soon, go ahead and submit it, and then take the exam for free. It's one way to prepare for it. The worst that can happen is you don't pass, but you get some really valuable insight into the exam. A lot of people pass it the first time, so we encourage that. Okay, and then you get your scores immediately. So, and when you do pass the exam, we want to take a picture of you with your exam score, and we'll put it on our wall of fame. Okay, so I was yeah, Nora to verify. Yes, I verified that this exam study set that we're showing right here is the correct one that's on the ACHE site. You can purchase that $295 from ACHE. We have a set of booklets, they're a little bit older. We do have a lending library, and in our last session, I'll be able to point out what books we have, what editions they are. And first come, first serve. As long as you're scheduled for the BOG, we can loan them out to you. Next. Okay, so this next one is the same set of booklets, but with the flashcards, and we can't emphasize enough how valuable these are. For each knowledge area, they'll have, the topic, and on the back, they'll have like the definition, and they'll have the reference of what they're referencing. People have found this very, very, very helpful. And okay, that's it for this section so far.
And would you like a receipt for today?
No, sir.
All right, boss.
Have a great day. Thank you.
Could you please mute yourself if you are, talking to the participant? Thank you.
Just one final note. These sessions have been pretty beneficial even for myself years ago when I started to prepare for it. But for every cohort that we've had great success. This is an example of one we got just a few weeks ago. I'm happy to share these here as well as on our website to help all of you get motivated. But thank you for joining us this Saturday, and I hope to see one of these testimonials from you. This is what Nora was referring to, our wall of fame, the recent successes we had. I hope this will be motivating for you guys to move forward. Thank you for joining.
So you may wonder why we do this on Saturday mornings, and we spend all year prepping for these. This is why. We want to see your face on there. We're so proud of this.
Indeed.
Okay, so we're going to cover this part throughout, the different sessions. Before you get to the exam, are you familiar with heart-focused breathing? Focus your attention, inhale, exhale for 5 seconds, it really does help. Again, relax before you get into the exam. One of the best tips ever is to read each of the options are true or false, and that's the secret of the brain walk that developed by our very own famous Rick, the Rick brain walk. Read and read each question. Beware of questions that have all of the above or all of the except or all but only, just those kinds of qualifiers make you need to focus more on the question. And then a good thing about, you have time, you have 6 hours. So take breaks, and also you can mark questions to come back to. So, so again, we'll be sprinkling tips throughout this whole thing. And again, our goal through these sessions is to give you as many resources as we have to assist you with studying. And in particular, the time we're on camera with you on this Zoom is concentrating on sample questions and how to interpret the questions or how to understand how they're structured. because that is what we've determined has been the most helpful in terms of providing you information to prep and then understanding how to take the exam. Okay. All right. On that note, we can now jump in. We're, pretty well on time to then cover the healthcare section. So on the introductory email that we sent out, it included the link to the recording from Rick on the healthcare section of the exam. And what we're going to do is go over, just point out some of the highlights of that section and then go through some sample questions. And we're going to give everybody an opportunity to weigh in on what they believe their answers are. Oh, and somebody has a question. Okay, yeah. At the end of the session, we'll be giving our contact information if you have any questions about the exam prep. Okay. Oh, we have someone from Pakistan. Welcome. We're international. I love it. Hi. I think you take the prize for like the furthest away at this point.
So
Okay.
before we proceed with the Q&A, let's probably give 2 minutes for any questions. Is that okay? From what we've seen, what you have seen right now from the slides, are there any additional questions? If you have no questions right now, in the future you don't hesitate to contact us, and we'll do our best to answer your questions.
I have a question, if I may. Tom Hansen, I'm based here in Fairfield, California. I'm actually taking the Board of Governors exam in December. I'm very excited about that. As I prep, I've got the materials, talking to many peers about, what they did to pass the exam. One major missing piece for me is a practice exam. And I'm curious if you guys have access to any practice exams. I know there's one out there on Google that's the questions are there, but there's no associated answers. Typically for any of these kind of exams, I like to take a practice exam and then see where I'm weak, and really target those areas. So back to you guys on that one.
So one of the things we do after each of these sessions, when literally we just send tons of information your way, we are including some sample questions and answers that have been provided in older ACHE BOG prep sessions. Granted, they're older. I should go back and explain that every year ACHE replaces some of the questions with newer questions, the ones that they were testing out before. So every 4 years, it's a new exam. But in general, even though these are some older questions, what we're teaching you here or what we're presenting is pretty much what those questions will help you with. So yeah, these are some older, for all intents and purposes, they're older practice exams with the questions and the answers.
Yeah, so an answer to that is there's no available practice questions that we can offer, like the one that you have in the Google is, sorry to say that it's obsolete, right? And I don't know if that's been like probably in there for years. So as Nora said, all the thing that we can offer is the one that we are sending every end of the session. So
there is also, and I'm going to qualify this, and we'll cover this later too. Initially, when the flashcards first came out, and when you order these, you get digital access too. But previously, they also had access in a Quizlet, which is like where teachers would go and make up their own exams and stuff. And there is an ACHE. Well, there is the flashcard site out there where there are sample, you can create your own true false, multiple choice. The key is ACHE isn't supporting that anymore. So we cannot verify that it's accurate anymore. But some people have found it helpful, but we can't verify that it's still accurate. ACHE doesn't support it anymore. But some people have found it helpful. So, but again, what we're sending out, even though it's older, at least the structure is still the same. So we'll be providing those sample questions for each knowledge area at the end of the sessions. Okay, hope that helps.
Okay, so thank you. Let's move on then to the main agenda of
The
this
main event.
session. Let's start with the healthcare, right? So I think that's also for Nora.
That'd be me.
We'll probably Shashan, are you ready to share the slide for the questions?
Sorry. Are you still seeing the old one?
Yes.
Okay, hold on.
While he's getting that going, I'm just going to do a quick introduction on some of the stuff. When I look at a question, and when you look at a question, don't just jump right to which one you think is the right answer, right? There's a tendency just to move along. You're feeling stressed. You're feeling a time constraint. There is no time constraint because 6 hours is way longer than you're going to need. So take your time with each question. Look at it and try to figure out what are they asking for? What are the key points here of it? Look for not all the above, except, any kind of qualifier like that. And then separately look at each one of the 4 choices that you get and do a true false, right? So look for it and say, okay, is answer A true or not? If you're not sure, hold it. Put it in your mind in a holding section. And then when you've eliminated, hopefully 3 of them, you got the right answer. If not, if you got it down to 2 and you can't do any better, well, 50-50 is a lot better than 25-75. So you're at least improving your chances that way. Okay, so again, take your time. Don't jump into it. And I bet when we open it up and say, give us your choices, everyone's going to do it immediately. Don't stop. Okay. So let's see the first question.
Yeah, and in addition to that, Rick, I would like to add also that if you aren't sure of your answer, mark it and you have the chance to review at the end before you finalize everything.
Yeah, get the low-hanging fruit and then go back and spend time on the harder ones. And I'm bailing out at 11, so let's move on this quickly.
Okay, all right. Okay, so again, so what we put here in the intro to the healthcare knowledge area, this is straight out of the ACHE website. Basically, they're telling you to prep for this, you need to have basic knowledge of healthcare and medical terminology, knowledge of healthcare trends, know the different levels of healthcare, like the continuum, levels of service from a business perspective, I mean, home health, inpatient, outpatient, they all have these different, areas that are specific to those lines of business. Types of different healthcare providers, not for profit, federal, public, that kind of stuff. No ancillary services, knowledge of support services. I mean, they're trying to give you this broad range of stuff that you need to know about. Next slide. And again, this is straight out of the website. So I love this long interdependency, integration. It's like, just, you got to know, just by being in virtue in this industry, it's more than just hospitals or doctors' offices. It's this whole scope, even insurance companies. Basic knowledge of clinical roles and, versus administrative roles. Different staff and functional perspectives. Nurses come from one perspective as opposed to the housekeeping staff. Patient perspective. How many of us, what I find interesting is that even though I'm in this industry, when I have to turn into a patient or the parent of a patient or the child of the patient, it's a whole different animal, isn't it? And the interrelationships between, healthcare access, quality, resource allocations, all those pesky ethical issues that come in this industry as well. Next. Okay, so we're going to start with sample questions. Like Rick said, don't just jump into this, but he's going to teach you his famous patented brain lock.
And just to let you know, I have not looked at these since last year, and therefore I'm, there's a chance I'm going to get them wrong. It happens. I think I get one or two wrong each session. But so improving profit. Okay, I'm looking at money here from a provider service network. Contracts. Okay, so the network is contracting with employers. And then here I'm getting the meat. So the contract is on a capitated basis and the providers pay fee for service. Obviously, I got to know what those two are. And how the question really is, how are we going to improve profit this way? So I got to know something about capitation, got to know something about fee for service. All right. So if and I'm looking at the network, I'm not looking at the provider. That's important. So increasing the number of inpatient procedures going to decrease profit for the provider. It's probably not going to. Oh, wait a minute. It's a provider service network. It's not a payer. I got that wrong. Okay. So I am looking at the provider.
Let me interrupt really quick, Rick.
Yeah.
One of our super secret recommendations, read the question backwards.
Yeah.
Read it backwards and you concentrate on who's asking the question and why,
Thomas, don't answer in too quickly. Hold on just a second. So that way you're also likely to catch the accept and the buts and things like that. Okay. So knowing that we're paid fee for service, if we increase the number of inpatient procedures, well, who's profiting here? The providers are, but the network probably is not. So I think that's a no. Reducing the per member per month rates to employers. No, that's definitely not going to save us money or improve our profit. Increase payment rates. Now, if we're paying more out, then we're not going to make more money. Reducing utilization services. So that's got to be false, because if we do that, we're more likely to increase the utilization. So if we're being
actually, that there we needed to added a word of reducing utilization of services.
Yeah.
So we need to.
I was thinking like utilization review. Yeah.
Yeah. No.
So okay. So now I've got A and D are opposites. One's increasing the number of procedures, the other is decreasing them. And so if we're being paid capitation, then reducing utilization is going to increase our profit, right? Because our money's coming in, but we're spending less. So from a provider viewpoint, I think D is the right answer. From a payer viewpoint, A is, and that's why it's so important to say, what do we mean by provider service network? But I'm going to go with D here.
Yep. So if we'd have read that answer backwards, we'd realize we're missing of in there. So we'll make that change right there.
Yeah, I didn't realize it was missing. I was interpreting it as utilization review.
Right.
Really would have been wrong, and that would have totally changed the answer. Then I would have just had 4 wrong answers. I'm trying to say, well, which one's most likely there? Yeah, someone said reminds me of the Kaiser model. Exactly. Except for the fee for service part. Yeah. Okay, let's go to the next one.
Well, and so, from the insurance perspective, I would have said reduce utilization of
Correct. You got to look at the right level.
Non-medically necessary services.
Okay, which of the following is true? Okay, that's good. So I'm hopefully just one of them is true about capitated arrangements. Again, I got to know what capitation is, right? So which of these is true? Provider shifts financial risk to the managed care organization. Nope, that's false. That's the opposite. Provider can bill separately for each service. No, that's fee for service, not capitation. That one's false. The provider must wait to bill the MCO until service has been provided. No, because we're not billing for each service. We're getting a per member per month payment. So I've got false, false, false without even reading it. D has to be true, I hope. And I look at it and said, yeah, providers paid a set fee. That's what capitation is. So D is going to be the right answer.
So can I say something on this question? So
No,
for me,
no, no, you can't. Just kidding.
Okay.
Sorry.
Remember, I'm bailing out a few minutes before 11, so
yeah,
I'll
but
take that.
I just want to make it a point that some of probably the test takers, the answer is very obvious, but even though the answer is obvious, still take time to review to read everything.
Exactly. Okay, next question. Okay, which of the following is not, okay, so I got to jump out there, not one of the reasons that HMOs, PPOs have lost traction in cost containment. So I'm looking at HMOs and PPOs particularly, and I'm looking at cost containment not working, lost traction, not working. So what is the reason? New technology has affected the amount and type of services demanded? Maybe, but probably not different for HMOs, PPOs than anyone else. Increased payments as a result of physician-hospital consolidation, leveraging negotiation. Yeah, that certainly happened. Consumer and provider dissatisfaction, worsening government intervention. Yeah, that's actually happened too. Affordable Care Act is banned PPOs. No, that one's false. So A and D are definitely false. So I've got it narrowed down to B and C, and I'm going to say which one of these is the best answer, right? So that's one of the confusing things. Sometimes they're both right, but you got one that's more right than the other. Okay, so I don't think we've had as much government intervention as we did, back in the late 80s, early 90s when, we had any willing provider and stuff like that. But we certainly, in recent years, and that back to the question, it says in recent years, we've had a lot of consolidation going on. So I'm going to go with B as being more true than C. What? No.
Okay,
Oh my
so,
God. Wait a minute. Oh, geez, I missed the not.
right? Okay,
I
see,
missed the not. Oh, I can't believe I did that. After I
Yeah.
specifically said I saw not, and then I totally ignored it. Yeah.
right. And yeah, so
Yeah.
see how just that little word changes the entire perspective.
Read. We say in law school, they used to say RTFQ, read the question. The F was silent.
So, yeah, so that was a good example of needing to make sure that you concentrate
read
on
it,
what
pay
they're
attention
asking.
to what you're reading. Yeah. Okay. How is ambulatory care delivered? Again, got to know what ambulatory care is. You ambulate, you walk in, you walk out. Okay. Medical staff membership, huh? Doesn't seem related. Patient preference is not a way of delivery. So I don't like either one of those. In community-based settings, ranging from home to physician offices to clinical, or an outpatient emergency department. Yeah, okay, that one's looking good. But let's look at 4. And 4 is really parallel to, or excuse me, D is really parallel to C. So I got to be careful here. Community-based setting range from home to physician offices, from home to acute care facilities. And then at the bottom here, the big difference between here is the inpatient versus outpatient. Well, inpatient is not ambulatory, outpatient is. So I'm going to say D is false, and I'm going to go with C. All right.
Most excellent.
Okay. One more, then I'm going to bail.
Okay.
More maybe. I've got a disaster training session for CalMet, so I've got to go to that at 11. Cost of graduate medical education are concerned to government policymakers. Well, this week, that's probably a bad question of anything being concerned, but okay. Cost of GME. Let's see. Number of residencies and residents are not centrally controlled. Well, I don't know a lot about GME, but that sounds maybe like something. Number of medical school graduates exceeds the number. Okay, well, yeah, that just means they don't get positions, they don't get a residency, but that's not a cost issue. We're concentrating on cost of GME. So B is false. Managed care organizations relatively uninvolved in payment. Yeah, no, I mean, that's, again, not related to the cost directly here. Managed care is not a specific. Many residency positions are filled by foreign graduates, again, not really related to cost. So I'm pretty sure I'm eliminating B, C, and D, although again, I don't know a lot about graduate medical education, but A is the one that sounds the most right to me with my lack of knowledge.
See, this is, and again, what Rick is beautifully pointing out, in general, if you're faced then with eliminating answers, usually the broadest one is the correct one. So, keep that in mind as well, because like Rick says, some are more right than others.
Yeah, and sometimes, you just don't know. None of us know everything in healthcare. It's too complicated. So sometimes all you can do is eliminate a couple of them and then make a guess as to which one sounds better. And if you've eliminated two, then you've improved your chances. Let's do one more.
Okay.
Oh God, initials. Yes.
I know, acronyms. Oh no.
You must know your TLAs, your 3-letter acronyms. It can't be in healthcare without TLAs. So which of the following is a unit of measure, or unit of measure commonly used for physician? So I'm looking at unit of measure and I'm looking at physician, and all these people are putting up an answer and they couldn't possibly have gone through all 4 of them. They're just jumping in. So slow down here. Okay, so you got to know what these are. Okay, RVU, relative value unit. Yep, that's a unit of measure, and it is clinical. So I think I like that one best, but I'm going to check the others. CMS, Center for Medicare Services, no. IPA type of beer. Oh no, Independent Practice Association, no. Central Processing Unit? I don't think so. So yeah, so I can confirm. Even though I liked A at the beginning, I confirmed the other 3 were wrong. They were false, and I'm going to go with A. Good.
Got it.
All right. I think I got time for 1 or 2 more.
Oh, okay, good.
We'll just keep going until I got a bail. Okay, what population demographic factor, so I'm looking at something demographics, having the greatest impact? I hate the word impact because impact doesn't tell me if it's a good impact or a bad impact. So I got to look at it both ways here. So I'm looking at demographics impacting healthcare. All right. And the word that's really going to bother me here is greatest, because that tells me that probably all of these are having an impact, and I've got to do a judgment call of which one. Okay. So, ethnic composition, I don't know that that's having a greatest impact. It's certainly having an impact, and a lot of that's because we're so much more aware of it. Insurance coverage, if you'd asked me this before 2012, I might have a different answer. But again, I think right now things are comparatively stable. Medicaid's a little weird, but ACHE isn't catching up with something that's happened in the last 3 months. I don't know of any big change on geographic distribution. Again, post-COVID, people moving out of the Bay Area, whatever. But yeah, age. Now, age is demographic. We have an aging population. We're moving into having to take care of more chronic things, more end-of-life issues. So all of them are demographic factors, but my judgment is that age is much more, having a much bigger impact than the other 3. So I'm going to go D.
Got it.
Okay, 1 more, then I'm going to go.
1 more.
Okay. Oh God, a long one. Okay, public reporting of outcome measures. So where are we reporting outcome measures? Well, CMS does that, and Leapfrog does, and others. Okay, so has become a high priority for the payer. Okay, so now I got to really concentrate on the payer. I'm not looking at consumers. I'm not looking at the providers. I'm looking at the payers. So why has public information about outcomes become a priority? So, okay. Measures of performance have now become well-established, standardized, accepted. Yeah, no, that's not true. Definite false there. Purchasers are pressuring for disclosure of information. Well, Leapfrog Group, yeah, that's an example of how businesses are pushing. So that's probably true. Consumers are now well organized. Yeah, I can stop reading there. That's not true. Physicians are increasingly encouraging their patients. Yeah, no, I wish. So, okay, so I know A is wrong because it's not standardized. I know consumers are not well organized, so that's false. Physicians are definitely not encouraging patients to do that. So I'm going to go with B. Okay, I'm going to go bail and go do some disaster training with CalMed. I will see everyone next week.
Thank you, Rick.
Bye.
Okay, so I'm going to take this opportunity to answer a couple of things that have come across in the chat. Somebody has a question about where to find out more about graduate medical education. This book has graduate medical education on pages 192, 93. This is the Well-Managed Healthcare Organization book. This is the Bible ACHE depends on. Someone else was asking about insurance not being a demographic. You know, I'll look up specifically what is considered a patient, you know, a demographic factor. But again, even if it wasn't specifically the demographic part, the question was greatest impact. Again, relative to everything else. So that's where that response came in terms of the age cohort. That's the one that's having the greatest impact at this point in time. And I'm hoping that helps clarify that. Okay, and discuss question number 7. Oh, is this the one? Yeah, this is the one we're looking at. Again, you know, what we concentrated on here is like, what is having the greatest impact? And if we had to look at these answers, the age cohort is definitely the one that's impacting this the most. Particularly if you're getting into rural areas, you know, we've got, you know, staffing and healthcare, you know, the staffing in subacute units and in skilled nursing homes, you know, I mean, that's right now is what's having the biggest.
And selections, and if I may add, selections for the answers sometimes, if you are not sure, pick the highest high level best answer. That's you know, because most of the selections are they seem like, you know, related to each other, but select the highest level answer to the question. So
Just want to add one more comment. The current, if you look at the current demographic of the US population in general, you know, the baby boomers retiring, chronic conditions still amount to a significant percentage of our healthcare spend. And if you add COVID complications to it, you have seen how these chronic conditions impact the morbidity part of it, but also is driving more of these patients into home health. You know, that's one of the kind of hot sectors right now, just because it's becoming harder and harder and more expensive to support or to take care of the older population that we have. So overall, I think there's too many factors that are just making this particular group very vulnerable, also most impactful on the cost.
yeah, so I would like to answer the question 6. Someone asked there, they're saying that insurance coverage is not a demographic. Yeah, it's true, because there are some selections sometimes that they are called noisance. They are just putting those selection there, and they tend to distract the test takers. That's why one of that insurance coverage is one of the distractor there. So yeah, it's true. It's not a demographic.
And so someone's got an acronym REAL for demographics. And if you can help, what does REAL stand for? And we can get back to that later. But I mean, because I was right now looking up to see, okay, what factors are considered patient demographics or population demographic factors. But see, this is why we do this. We like to get into these kinds of discussions. And again, this covered a whole bunch of things. You know, we're looking at picking out that word greatest. and we'll be emphasizing this throughout the series. Concentrate on what the question is asking, and then find the answer through the true false that makes the most sense, the broadest. And remember, this is not state specific, this is nationwide. Oh, race, ethnicity, age, and language. Okay, thank you for that. I don't think I'd seen that before. I like it. Okay.
We will clarify that on our next email for that, though the race.
Yeah, I like it. Okay. Okay, so yeah, we're okay. Oh, this is a good one. I never remember this answer, so I had to write it down so I could be sure. Okay. Okay, health savings accounts, HSAs, were established through which law? So apparently there is only one law that established them, so that we know we can't, so we have to choose one of these. And so we've got the Consolidated Omnibus Budget Reconciliation Act, which is COBRA, Medicare Prescription Drug Improvement and Modernization Act, Health Insurance Portability and Accountability Act, otherwise known as HIPAA, and Americans with Disabilities Act, which is ADA. Okay, I believe that right away, I don't believe ADA had anything to do with health savings accounts. So I'm going to take that off the table. Health Insurance Portability and Accountability Act, I don't believe HIPAA had anything to do with that either. So I'm taking that out. COBRA, again, us with our famous acronyms. COBRA came out a while ago, and and HSAs are relatively new, so I'm going to eliminate that one as well. So I'm thinking, so the Medicare Prescription Drug Improvement and Modernization Act came out, I don't know, Rick would know if he were here, I don't know, 7 years ago? Somewhere around there. So I'm thinking it's B. Oh, okay. So, so truly, I do not recall specifically what was in each one of these. It's been a while since I looked them up.
Just a
But
quick
my
comment.
I'm sorry?
I know we early on said, they're not going to test book learning. And this is one aspect of book learning, which is really, you need to be familiar with. There's no logic to it. Some of the ways our legislators up there have created these acts, they don't necessarily stand out exactly for what they say. They add some more amendments to it. So don't go just by the wording. So what I did was, for most of these acts and or legislations that were referred in the books, I made kind of an Excel sheet or some lookup list. So
Grid.
that was passed, as well as the 2 or 3 things that jump out of that. So it kind of helps you memorize it. That's the only way to remember it easily, unless you're dealing with laws and regulations every day.
So this is a good example to this question. We have this in there primarily to exactly what Sachin was just saying. And also this conceivably could have been put in the laws and regulations section. So when you're taking the exam, sometimes it's not clear, which knowledge area it's in, but they overlap. I mean, there's so much overlap. So, but again, like Sachin was saying, even if you don't know specifically, process of elimination, I at least had a 50-50 chance at that point. Okay, so next question. Okay, oh, this is a good one. I don't think I remember seeing this one. These must be new questions. The demand for nursing care is a function of 2 elements. Okay. Okay, nursing care, 2 elements. Okay. The number of patients and the physicians on staff. Next one, number of patients and how sick they are, i.e. acuity. Number of patients and acuity. That one I like better. The number of physicians on staff and their specialties. Well, definitely different units and different specialties have different requirements, but you know, I don't know. I'm reading this kind of as staffing levels, kind of, and the number of PHO and HMO contracts. Yeah, no, that I may be eliminating that one too quickly, but I believe it's B, because you're looking at the number of patients and the acuity levels. And that's where, if you're looking at daily staffing or staffing ratios, that's how I interpret that to be. So it looks like I'm correct. And looks like everybody pretty much is correct there. So I'm hoping that my logic flow made sense. Although there's a danger in assuming what the question was meaning. But so I took it literally from what I recall having to know when I worked at a hospital, being very, very careful about, you know, nursing hours and staffing and acuity. Okay, next. Okay, so what is the order of the healthcare continuum? So this is assuming that you know what the healthcare continuum is. And so, and it's the order of it. So let's see. Okay, long-term, acute, palliative, and primary care. Right away, we can eliminate that one because, you know, long-term care is not the beginning of the continuum. I believe primary care to be. So let's next one. Pediatric, well, that's a good one. Starting out when they're young. Pediatric, medical, surgical, and acute. No, that's not the continuum. That's so we can eliminate that one. Okay, all right, here we go. Something's starting to look good. Primary, acute, long-term, and palliative. I like that one. That's what I'm familiar with. And then D, acute, surgical, palliative, and long-term. No, because that doesn't deal, yeah, that doesn't address the very beginning of the continuum in this context with primary, acute, long-term, and palliative. So I choose C. And it looks like all of us are doing that. Okay.
So may I say something on this, Nora? So this is more this question is more on chronological order, not testing your knowledge of chronological order of events. So if you know the event of a healthcare continuum, the first and last, you're able to eliminate other selection right away, right? So if you know the primary and as the first and palliative being the last one, so as you read through the selection, you're eliminating A because long term is not the start, pediatric is not the start. So you can apply the process of elimination in this question.
Okay, next. Okay. Your board of trustees has voted to terminate the privileges of a physician. Okay. Which of the following organizations must you inform? Okay, so we know it's got to be one of, you know, it's not saying which. Well, so which of the following, I guess you could choose more than one if you're looking at this, but so is it AMA, your local medical society, the National Practitioner Database, or the Joint Commission? Again, right away, we can eliminate Joint Commission. We can eliminate AMA. Do we need to tell our local medical society? No. So yeah, National Practitioner Database. Is that correct? Yes, yes, it is. And again, I may have sounded, you know, like this is just too simplistic because most of us would know that. But again, you know, the question, go ahead and read through and eliminate logically, I guess is what we're trying to say on this. And again, some of these are easier than others. And I think we have
Federal.
one more question.
Federal.
Go
The
ahead.
National Practitioner Data Bank is a federal, so you don't, and most of the questions are federal questions.
Oh, there you go. You're right. You're right. Good point. Okay. And last question. Okay, which Medicare plan allows the enrollees to participate in private health plans? Okay, so this is assuming that you understand the different parts of Medicare. So we've got Part A, Part C, Part D, and Part B. Okay, Part A is the Medicare hospitalization.
Mhm.
Part C is the Medicare Advantage. Part D is the drug, and Part B is the doctors. So, okay, I'm sorry, were you trying to answer the question? Oh, okay. So, and we've got some B's and some C's. Okay, so understanding that Part C is the Medicare Advantage one, that's where private insurance plans allow members to enroll in those plans. And actually, technically, you're giving up your Medicare card when you go to this and you use a private health plan. Now, the private health plans have to abide by Medicare guidelines. That's a whole other story. So, so yeah, so the answer is B. Okay. So I'm not as practiced as at the Brick Brainwalk as Rick is, but I hope that helped, again, try to point out how to eliminate the most least likely and concentrate on the most likely. And again, it's not, we're not trying to give you the information you need to study. We're giving you the resources that we believe are helpful, pointing you to the ACHE site, wealth of information, lots of good stuff out there on the in the flashcards. You know, some of the references that they use in the flashcards aren't just the study materials that ACHE requires or recommends, but they all kinds of references. This one here for economies of scale, the reference is Strategic Healthcare Management and Planning and Execution by Walston. So that's not even one of the recommended ones, but a lot of people have found the flashcards to be very, very, very helpful, as well as Rick had indicated early on that even if all you study is a well-managed healthcare organization, that covers a lot of information.
So, Nora, can we have like 15 minutes left. Can we, do the supplemental questions, even just like 5 or 6? So, Shashan, would you be able to share the supplemental questions? So, for the supplemental questions, we encourage you to put your answers in the chat box. So this is just a question and answers that we have prepared for you. So let's go through it.
So again, as I indicated at the beginning, you know, we're finding as many older ACHE supported questions from days gone by. And again, some of these may be older, but again, it's the structure and it's in the logic flow that we're trying to concentrate on in this session.
Give me 1 minute.
Sure.
Anybody have any additional questions that we didn't answer that came up earlier on the chats? And we're trying to keep track, and so we'll be following up on some questions, in future sessions.
Nora, hi, it's Nicole Silva, and hello to everybody. I'm from the Bay Area here in California. I do have a question about the typical exam taker. Do you guys have any statistics around the length of their career career, typical background, etc., of who sits for the Board of Governors exam?
No, we don't have any specifics about that, because, ACHE actually removed the requirements of how many years you had to be a member. So, what we've seen in our sessions and in other sessions that we've participated in with other chapters across the country, it's a broad section. We've got some new executives coming in, that are relatively new in their careers. We've got some that have been in their careers for years and have finally decided to take the plunge and try to get the credential. So, it's across the board, young, old, young careerists, mid-careers, late
I
careerists.
have it here, Sashan. I'm sorry. It's already in the
Thank you.
Okay. All right, so here's some more supplemental questions. Okay, so first question is,
let me
so I hope that answered, I hope that helped. Oh, and somebody's talking about a YouTube series. Okay, we'll get back to that. Okay, I'm sorry.
let me play it. Okay, hold on.
And these are recorded and put on YouTube. We give you the link after each session. We're world famous.
Okay, so the first question. Go ahead, Nora.
Okay. Oh, great. Okay, a management approach that relies heavily on performance measurement, identification of best practices, and formal process specification is that evidence-based management, interdisciplinary plan of care, service excellence, or point of service approach? Management approach that relies heavily on performance measurement, identification of best practices. Okay, so I'm liking evidence-based management at this point because they're actually looking at results of something, some sort of evidence. Interdisciplinary plan of care. We're not talking plan of care when you're actually talking about clinical care is how I'm interpreting that one. Service excellence. I don't believe that that's the correct context for this one. And then point of service approach. That's also not the context of this question. So I'm choosing evidence-based management.
Okay, and survey says you're
There we
right.
go. Okay.
Okay, next question.
Okay. Oh, well, we had this question earlier, just worded differently now.
Okay.
Medical care provided on an outpatient basis is called urgent care. Well, that is a form of medical care. Again, let's look at the broadest answer: ambulatory care, emergency care, or Medicare. Okay, Medicare
It's eliminated.
is not a medical care service in and of itself. Previously, we'd answered ambulatory care, and remembering that urgent care and emergency care are part of the ambulatory care setting. So answer is B.
Right.
There, you got it.
Next question.
And again, you can think you can jump to the answer right away, but please, please, please still go through that process. Okay, a physician who manages broad categories of hospitalized patients is an general practice physician, hospitalist, internal medicine physicians, or cardiologists. Okay, key here, hospitalized patients. They're not asking about a physician who manages a broad categories of patients. So right away, my mind is jumping to hospitalist, but are we sure none of the others are correct? And again, I'm sorry.
I'm seeing B here as the answers for the chat box. So
Okay, and answer is?
Answer is. Oops. something wrong.
There it is. And again,
just
sometimes that keyword is what'll take you there. But again, we still recommend going through that elimination process.
A quick comment on that. As we know, general practice physician and internal medicine physicians who are contracted with hospitals can admit patients into the hospital, especially if it's their own patients. But hospital, as we know, hospitalist as a role, those are the physicians who are basically hired directly by the hospital or through the foundation, where they are stationed on a full-time basis, and especially during emergency care or inpatient care, they are the ones that actually are there right away, accessible. So in this case, that's the broadest answer, because these other options are plausible, because even cardiologists actually are on call or on consults with the hospitals. But the broadest and most relevant in this case is B.
And let me correct you a little bit. No, it's not a correction. Let me add to what Sachin said. A lot of IPAs, independent physician associations, like insurance companies contract with, and a lot of medical groups now have their own, on their own panel, hospitalists that do nothing but manage their patients. So that evolution is interesting. But you're right. So the other answers are primarily talking about the specialty of the patients that they take care of, but in terms of managing hospitalized patients, right, we're talking about the hospitalist. Okay. What links financial incentives to the quality of care provided? What links financial incentives to quality of care? Are we talking HEDIS, which is what HEDIS is, the health, I'll remember the acronym shortly, but it's a series of measures, right? Quality measures that are the ideal, right? Patient satisfaction score, value-based purchasing, or population health. Okay, so what links financial incentives to the quality of care provided? Okay, so the key is what's linking the quality of care to getting more money.
Sorry,
Yeah, there. No, that's fine, because I was about to say, we're talking about the link. So HEDIS is a form of measurement. Patient satisfaction score is a measurement. Population health has a series of measurements in there. If when you're talking about population health, what is it that you're looking at over a broad range of people? But what links those is the value-based purchasing. And we got some right answers here. Okay, well, and there we go. Okay, here's a true or false. We need to be wrapped. Let's have this be the last question.
okay.
True or false? And this is Rick's bailiwick. Okay, is it true or false that a patient's self-determination or the right to make decisions regarding their own healthcare is called patient autonomy? Okay, true or false? And we're getting trues, and the answer is
And survey says true.
true. Yes. Okay.
Okay.
All right. So okay, I'm going to turn it over to Michael at this point. Thank you for participating in this. The questions.
So let's just wrap up. So it's 11:26, and we will after this session we will send you the recording and some additional resources, questions next week, probably by Tuesday, right, Sasha? That's our goal. So we will send those additional helpful resources for you to prepare for the exam. And we will be tackling
when it comes to citing sources.
Oh, sorry, who's that? Okay. So we will be tackling
Matter.
the healthcare business and
features. Instant, automated, and seamless.
who's please mute yourself if you are not talking, please. So we will be sending we will be doing the healthcare business and management and leadership next week. The same time, 10 o'clock. So we will be doing, we will have Q&A, the same process that we did today. And as you know, Nora said, we thank you for being with us today for this first session of our BOG prep class. So we hope to see you again Saturday, and have a good day and have a great weekend to all of you. And we're giving you 3 minutes gift of time.
Thank you all.
Thank you, everyone.